In this video, we're going to talk about acute coronary syndrome. This is important because this is how most of us are going to die. It's the #1 killer around the world in the United States. It's secondary to ischemic heart disease. So basically, our coronary vessels, the blood vessels that take blood and oxygen to our heart muscle itself, get blocked, and it results in death of tissue when you have myocardial infarction or heart attack. So what is happening on a pathophysiological level is that our coronary vessels, over time, atherosclerosis builds up. And I made a video on atherosclerosis and prevention of it, but you get these fatty plaques build up, and they kind of get covered by this protective fibrous cap. It's like the little smooth muscle actually goes up and secretes a matrix of collagen to kind of wall off that plaque. And that's a good thing, but it can rupture. And when it ruptures, that collagen fibrous plaque is off, and the underlying stuff is really sticky to platelets. So you get platelet aggregation, and it forms a thrombus on top of the plaque, and that thrombus can actually completely occlude the lumen or get it close to occlusion. And so that's when you start getting these acute coronary syndrome symptoms. And what are those symptoms? Symptoms include some autonomic response, diaphoresis, like you're sweating. You have nausea and vomiting. You can have cold extremities because your blood's getting shunted to the important organs and away from the skin. You can get hypotension. This can lead to cardiac shock and death if your blood pressure gets so low that you're not getting perfusion to the heart itself and to the brain. One thing to make note of is that some women, some elderly, and people who have had a heart transplant, they may have a silent MI because they don't have these same sequelae of events that happen as far as symptoms go. So there's this spectrum of angina, like stable angina. This isn't included in acute coronary syndrome, but stable angina is where you have plenty of perfusion at rest. Your coronary artery is 70% occluded, so that 30% part of the lumen allows enough blood to get to the heart muscle, the myocardium, while you're at rest. But then upon exertion, like exercise or going up steps or something, you may get some chest pain that's relieved after you calm down. So that's stable angina. And there's another one called Prinzmetal angina. This is not related to atherosclerosis. And this one is just where you have a vasospasm of the smooth muscle of the coronary arteries, and it can cause chest pain, especially at night. But I just wanted to mention those. But those aren't included in acute coronary syndrome. There's 3 subtypes going from least problematic to most problematic, which is unstable angina, where you have chest pain at rest and it lingers. So you're going to have this a little bit longer than it's not relieved by relaxation and resting. And then NSTEMI and STEMI, these are 2 different types of myocardial infarction. So these are both heart attacks, STEMI being the worst. So with NSTEMI, where they get this name from is it's non-ST elevation myocardial infarction, which means if we have our ECG here, this is our P wave, Q, R, S. S should be down here on the, down here. It's actually elevated from S to T. So our T wave and our S wave, they're elevated. What this indicates is that we have a full wall transmural infarction. So these are called infarctions because when you have infarctions, you actually have death of the myocardium, the cells of the myocardium. Whereas unstable angina, an important distinction is this is just ischemia. This is just lack of oxygen, but it's not causing the death of the underlying myocardium. So STEMI means that it is completely eliminating oxygen to that entire wall. Whereas in STEMI, it's just getting just underneath the endocardium there. So it's not a transmural infarction. It's just a partial wall infarction there. One big distinguisher between unstable angina and the 2 that make up myocardial infarction is that when you do blood work, you look at the blood, you look at blood markers for myocardiocyte death, and those are creatine kinase MB and troponins, especially I and T troponins. So these will be elevated if you've had a heart attack or MI. They're not elevated when you have unstable angina because the cells aren't dying. When the cells die, they lyse and they release some of the proteins that they have within them. You know, the troponins are needed with the myosin and actin and the contraction, and then creatine kinase is in there too. So, and the MB is specific to the heart cells, so those get released, and you know you're having a heart attack there. You know you're having a heart attack, especially when you have this ST elevation. Now, unstable angina and NSTEMIs, they can have some ECG changes. They may have a depression of the ST segment, or they may have an inverted T wave where the T wave is going down instead of up. Of course, you have a 12-lead EKG, and not all of them are going to have NSTEMIs when you have a STEMI. It's just going to be the ones, the 12-lead EKG tells you what part of the heart is involved, and so you can know exactly where the infarction is by which leads have the elevated ST segment. So with all of these, you get to at least 90% blockage. These two are at least 90% blockage when you have unstable angina and NSTEMI of the coronary artery. But the STEMI is 100% blockage. Like there is nothing getting around in that around that thrombus in the coronary artery. So one distinction here I want to make is one of the complications after an MI is another MI. So you can look at these. The creatine kinase MB isoenzyme is elevated and it normalizes quicker. So if you have than troponins do. So if you have it normalized and then they spike again, you know you've had a second MI. Whereas troponins take a little bit longer to normalize. So that's one thing. That's why it's good to kind of have both, as you can kind of keep an eye on that second myocardial infarction as a complication. So let's talk about treatment of acute coronary syndrome at the moment when this happens. So immediately, the best thing you can do is get some kind of antiplatelet in your system. Your platelets are sticking to each other. They're sticky now. They're going to stick to that inner plaque substance, and they're going to stick to each other. So if you can get aspirin in your system, chew it up, let it dissolve under your tongue, get in your system really quick, you know, swallow one, whatever, get it in your system immediately. That's just going to limit the number of platelets that add to that thrombus. It's not going to be thrombolytic and take away the thrombus that's already there, but you're going to limit the amount that's added to it and prevent complications, and maybe allow a little bit more blood flow through that coronary artery and less infarction of the tissue. So that's really important. Clopidogrel or Plavix, they just work through different mechanisms. This one decreases thromboxane A2 production in the platelet, whereas clopidogrel blocks the P2Y12 receptors that are needed to get ADP production. ADP causes platelet aggregation as well. So, but these work through two different actions, and they're both antiplatelet medications. And then you want to get nitroglycerin in your system because, for one, it's going to dilate the coronary arteries. Maybe that opens the lumen enough to get a little bit more oxygen through. Two is that it dilates the veins. So that's going to decrease your preload coming into the heart, which is going to reduce the workload on the heart, reduce the oxygen demand of the heart, and help the heart not get too overwhelmed and overworked during this process. So those are kind of get that in your system immediately kind of thing. Aspirin's so inexpensive. It's good to just keep it on you at all times. Keep it in your purse, keep it at home. And if you start having chest pain, pop one, you know, or chew it up, get it under your tongue, because that's going to be a quicker delivery if you feel like it's acutely coming on. So that's out of the gate. And then some other things that the physicians may do, you know, once you get in there, they may start you on a beta blocker, because a beta blocker is going to decrease the oxygen demand of the heart. So it slows your heart rate because it inhibits the sympathetic nervous system. So it's going to lower your heart rate. Lowering your heart rate reduces your stroke volume and cardiac output, your cardiac output. So that's going to reduce your blood pressure. It's going to reduce your workload. And so that heart's already stressed and, you know, out of control trying to keep up. So if you can reduce the oxygen demand, that's a good thing. And kind of the same thing with calcium channel blockers. If you take the pyrimidine calcium channel blockers like amlodipine or nifedipine, you're going to decrease the workload on the heart because you can dilate the arteries. So if you dilate the arteries, you have less you have to push through, and that heart muscle doesn't have to push as hard. So that might be another thing the doctors, in the ER might kind of get going as well. If you're going to get a cath, so if you're going to the cath lab, that means you're going to get a percutaneous intervention. So what happens here is they will take a catheter and they will usually run it up through the femoral artery, go all the way in to where that blockage is, and then they'll kind of open up a balloon, pump up a balloon, and that balloon will push that plaque and thrombus and everything up against the walls and recanalize that coronary artery and reperfuse the heart muscle itself. So even what's really cool about these is some of them actually release some like antiplatelet, anticoagulant to prevent anything sticking to the actual stent itself. So that's called balloon angioplasty is another name for that. If an alternative, so if you're going to do that, usually they'll put you on some type of heparin drip. So that anticoagulant will just help with the process of things not sticking to the new stent and stuff like that. So that's something they would do if you're going to the cath lab. That happen. It's an emergency to get to the cath lab and get a PCI or something else if you have a STEMI, because each minute that goes by without perfusion, you're having more infarction or necrosis of the actual heart muscle. So that's important. In-STEMI and stable angina, they'll kind of weigh things out. They may do a stress test. It's not as emergent to get to the cath lab, but that's a treatment option for those as well. An alternative to the balloon angioplasty is a CABG, a coronary artery bypass graft. A lot of times with this one, it's open heart surgery, so they'll open up the sternum, and a lot of times they'll use a saphenous vein from the leg, and those can be kind of tedious to dig out. I've done them in a lot of cadavers because they'll use the cadaver saphenous vein for some bypass grafts, maybe for peripheral artery disease or something like that. But basically, there's so many tributaries and everything, and we would take it from the foot all the way up to the groin, and it's really easy to get sidetracked and miss and cut into the main channel. So it's one of those things that takes some practice, and after some practice you get good at it. But they'll take little segments of that and bypass around the blockage. And another kind of redundant artery around the heart is called the mammillary artery. They can use that one as a bypass as well. But it's kind of interesting surgery. When I've watched these surgeries, they'll put the patient on a heart-lung bypass machine, and their blood pressure would stay at 90 over 90. And they would, I don't know if they still do this, but 20 years ago, they would pack it with ice and it would just kind of slowly quit beating. That's a CABG, or coronary artery bypass graft. And then if you don't have access to this, maybe you're in a rural hospital, or just the timing's off, you got to get reperfusion somehow. So they may do something like a thrombolytic, like alteplase, rectoplase, tenecteplase. These are different tissue plasminogen activators that can go in, and they're clot busters. So they'll go in and actually activate plasmin, and plasmin degrades the clot and recanalizes that coronary artery. So acute coronary syndrome, we talked about the symptoms. We talked about the 3 different types. We talked about diagnosis and acute treatment. And I hope this video helped you. Thank you.